Or
would be worth making a start.
Yeah,
Do
I'm
that.
not sure how many have booked on, but I would probably make a start, and then anyone that joins late, they can catch up with the recording.
happy to. So I'll
Well, we have
share.
one out. There's no men on it. You're women.
Can we ask people to make like
I'll make a start if people can just pop themselves on mute.
There's lots of interference in the background. Not sure if someone's got a speaker on the TV.
you might be able to ask Katie to mute everyone.
Bear with me, I'll have a look now for you, bear with me.
I'll just pause for a minute until we sort the sound out. That sounds a bit better, so I'll make a start. I'm conscious of time. Thank you for joining today or for listening to this recording afterwards. This is about the new MEED guidelines for the management of medical emergencies in eating disorders. My name is Magdalene Sampson, so I'm the lead and a clinical psychologist from the GMMH Community Adult Eating Disorder Service. And I'm joined today by Angela Hughes, who's our senior dietitian here, and who's going to also run through refeeding syndrome as part of this session as well. And in terms of, we provide a service to Bury, and I'm just going to start by just quickly outlining what the pathways are for adult eating disorders in your area. I'm then going to move on to highlight why the MEED guidelines are important. That might seem obvious, but we know that the previous two sets of marzipan guidelines, there was low uptake of those and low awareness, and we're really keen that the MEED guideline is far more impactful. I'm going to move on then to highlight the new MEED risk assessment tool and highlight where that is in the guideline. I'll also then move on to highlight where the quick reference guide is for GPs and primary care, which is a two-page document as well. I'll then just briefly finish my section by highlighting the strategy for trying to make MEED impactful over the Bury area and the other areas of GMMH footprint and wider across GM as well. And then I'm going to hand over to Angela, who's one of our senior dietitians, who's going to talk through refeeding syndrome, and then we'll just finish with some resources. If there are any questions, if you want to put those in the chat, and I'm not going to be able to monitor that because I'm sharing the slides myself, but Kelly is going to keep an eye on that, and if there's anything that we can't answer today, either because of time constraints or if it's something we want to take away and then get back to you on, we are very happy to do that. So please do put questions in the chat. I'll start with just outlining the pathways for adult eating disorder services in Bury, and basically what we've got here in the cracker is we've got primary care at the left hand side, and then most people who have an eating disorder and are adults, so over the age of 18, there's no upper age cut-off to who we accept as a service. But most people can and should be seen in community eating disorder services. What we've got then on the right hand side, which is our focus for today, is the people who need more intensive treatment, That will be in terms of across a year in Bury, will probably only be a very small number, less than a handful of people who will need that more intensive support, which is provided at the Priory at Cheadle, and is via the new provider collaborative contract, which sits over the Northwest. We make those referrals, so as the community team, we make those referrals, and that goes to both the Northwest Provider Collaborative and to the Priory themselves for consideration. I've included again on the right hand side about the acute side and acute hospitals and MEED, and where MEED fits in, particularly in terms of the pathway, because there'll be again a very small number of people. It might be just a couple a year who in your area who have more intensive needs and are physically very risky and need to be admitted to a medical ward for some stabilisation, and then will either go to the Priory or may come out to the community. MEED is particularly focused on that group, but I've put along the top that MEED is for all of us to know about in whatever part of and whatever setting and part of the pathway we might be in, because obviously people can turn up at primary care and be extremely unwell as well. I've also just included on this diagram under the MEED part of the acute hospitals about minding gaps, because that's where we know that serious incidents can occur and can be a particularly risky time for people. We also, just a final bit on this slide in terms of the provision of community adult eating disorder services. At GMMH, we cover 7 of the 10 GM localities, the other 2 providers being Cheshire and Wirral, which cover Bolton and Trafford, and Oakwood Psychology, which covered Stockport. Just again, a little bit more detail about what our previous service contract was and the new contract which we are currently mobilising towards delivering. So in terms of the contract that we had to deliver community adult eating disorders to adults in Bury, what we were commissioned to provide was a range of high quality, nice, concordant, evidence-based psychological therapies, which are first line treatments for adults with eating disorders. And these well-developed psychological therapies that can help 50 to 70% of people have full recovery. We were also commissioned to provide specialist dietetics, and we also provided carer support, psychoeducation and support groups to support those supporting people who have an eating disorder. Our responsibility was also to refer to the intensive parts of the eating disorder pathway, and when people were admitted to the Priory, to attend CPAs to contribute to discharge planning following that. There was a very small contract, so pre-2010 we were commissioned to see 7 people a year from your area, and from 2010 to 2022 that was 25 people. I'm just including those numbers because in terms of one of our ambitions here at GMMH was to increase the capacity we were commissioned to deliver to, so that we could see all people in a more responsive way. There was a new contract that was agreed and commissioned from February of this year, which we are really pleased that's in place. And we are currently mobilising and recruiting to then deliver that new contract. Our ambitions for Bury, as well as the other areas that we provide to, were to increase capacity. So the current capacity is now 71 people a year. To provide medical monitoring and management pathway, and there's just less than a day funded of psychiatry input and a session of HCA input. What we recognised is that the frequency and the specialist nature of the medical monitoring and management was at times often beyond a very stretched primary care system, and so therefore we wanted to support that. And so we have funding for that, and we are currently recruiting a psychiatrist, but significant challenges to that because of there being a very low number of eating disorder psychiatrists available. The third element of the new contract was to launch a freed early intervention pathway. So this is a specific pathway for 18 to 25-year-olds who have a short duration of illness, so 3 years or less, and to get in early to provide evidence-based psychological therapies, dietetic support, carer support, to really avoid problems building for that group and it having more of an impact. And there's lots of evidence that outcomes improve if we can get in early, from 50 to 70% for recovery. We are also bringing back family therapy, which we had in our service before, to support transitions and people who need that wider sort of input. Developing a pathway for severe and enduring presentations that will focus on quality of life and that medical stabilisation, and looking at increasing access of underrepresented groups. And one of the messages, even though it's not specifically related to MEED, that we'd like to share with you today is that anybody of any age, gender, background, ethnic or cultural, can develop an eating disorder. That's just a little bit on access. So we do have a referral pro forma. There's our contact details on there and the inclusion and exclusion criteria as well. We've always tried to be a very inclusive service, and to a degree that's why we've had waiting lists in the past, because we have taken people from the mild to moderate presentations as well as more moderate to severe as well. I'm not going to go through this slide in any detail, but this is just a summary of the NICE guidelines for the psychological interventions, which are the first line interventions for adults with eating disorders. So I'm going to move on now to the focus of today, which is MEED and the new MEED guidelines, which were just launched in May. As you may be aware, they've now replaced the Marzipan guidelines, so the second edition, which was in place from 2014. Marzipan was management of really sick patients with anorexia nervosa, and MEED has now superseded that. You may be as well aware as well that there was a junior Marzipan that was brought in 2012. And that had a very helpful app that is going to be developed in the MEED guidelines as well. So MEED, in terms of its development, and Marzipan originally, has been developed to reduce preventable deaths of patients with eating disorders, specifically on acute general wards, but of course it's relevant in all settings in healthcare. In the Bury area, the reason why we're supporting this so much, and we will continue to do, is because of a death that you may be aware of in the Bury area, of somebody who was in her 30s, who died tragically in terms of the care that she received. And one of the quotes from the Regulation 28, which was given from the inquest, was that Nicola had been seen by 30 members of the medical profession during a number of admissions to Fairfield over 2020, and at the inquest one person said they had knowledge of Marzipan and that was limited, and other people at the inquest said they weren't aware of the guidelines and how to deliver care when somebody is so unwell as Nicola was. The other reason Marzipan is important, sorry, MEED, following on from Marzipan, is important, is following ignoring the alarms report, which again you may have seen through communication. This was following inquests, a series of inquests that were done in the Cambridgeshire area, and this report was written in 2017. And one of the recommendations was to increase knowledge and training across healthcare systems of marzipan as it was at that time. Marzipan was developed, as I've mentioned, to reduce preventable deaths. And one of the reasons that it's so needed is because people are often concerned about refeeding syndrome. And actually what there's been case studies where then people have been so cautious on medical units and in other settings as well, community settings, that actually it's resulted in underfeeding syndrome. And we've got Angela here who will be picking up about refeeding syndrome in a moment. And the MEED guidelines have very detailed, description of around how to avoid both refeeding syndrome and underfeeding syndrome. So a case from not from our part of the world, but somebody who had chest pain, mild liver abnormalities. She wasn't fed during the admission to a medical ward due to fear of refeeding syndrome, and she died after 7 days of being on 0 calories. You're probably very aware of this, but eating disorders have the highest mortality of any psychiatric diagnosis, and 80% of adults, in terms of the mortality rate, that will be from the effects of starvation, and 20% from suicide. Another couple of case studies, again, not from our part of the world, but somebody admitted with low potassium corrected, discharged, but found dead in bed 14 days later. And one of the things that came through with the inquest of Nicola was that medical stability being so fragile. And actually, you know, if she could have been kept in the medical ward, and we know there's a lot of pressures to do that, and then had that direct transfer, then potentially that could have been a different outcome. Second case study, so somebody admitted to a medical ward at BMI of 10.8, which obviously a very, very critically low BMI, not fed for 4 days while liver function was investigated, and hyperglycemia, was untreated and died in a hyperglycemic coma. And one of the messages that really comes through from MEED and is in the quick reference guide is not to delay treatment while other investigations are being carried out. The final reason why MEED is so important is because you may be aware there's been a real surge of prevalence of eating disorder cases and referrals across all age groups over the past 2 years, and COVID, it's been a particularly challenging time for both young people and adults, and there's been a significant rise as well in hospital admissions. So there are more people presenting both for community treatment in, to primary care, but also to the hospital settings as well. It just seems to have just got stuck moving the slide along, if you bear with me. Apologies about that. That moved on. Can I just check? Can you still hear me?
Yeah,
Yes.
that's absolutely
Yes.
fine.
Thank you. Brilliant. Apologies about that. It just got a little bit stuck in the movement. I'm not going to go through this slide, but it just shows that increase in hospital admissions, and 70% of those numbers are adults, 30% children. How MEED has improved from marzipan, it's all age. So instead of having 2 sets of guidelines, there's now one for all the age range. It's around all eating disorders, so not just those with anorexia, but all, they will be, I guess, the most frequent people that MEED will be applicable to, but it includes as well people with type 1 diabetes and eating disorders, as well as those people who will have electrolyte disturbance and might have bulimia in a very severe way. And I think those particular groups that were perhaps neglected before, there wasn't clear guidance on their management. The name has changed, so feedback from service users and carers was that having a food title wasn't great, and so MEED is more acceptable to marzipan. The shared risk assessment, which is pages 31 to 34, which I'm going to show you in a moment, with a very clear traffic light system, has been adopted in the MEED guidelines, building on the positive feedback about that risk assessment from the junior marzipan guidelines. And also there's very clear kind of table about how to manage any risks, which is page 36 to 38 of the guideline, which again is much clearer than previous marzipan guidelines for adults. The next point is it clarifies basing a risk assessment not solely on weight or BMI, but looking at a far more holistic assessment based on the physical parameters and other factors related to support that's available from carers and kind of people's ability to kind of put things into place to reduce risks. It reviews the latest evidence base from both UK and international guidelines, which is at the end of the document, which is really good to see how our risk assessment and management compares to other countries. It clarifies rates of refeeding, which is helpful because there was some different practice that was occurring from marzipan and then from what was happening at specialist inpatient units and the general NICE guideline for management of nutrition. I've mentioned that there's a new part on management of type 1 diabetes and eating disorders, which is really welcome because they're a particularly risky group. It's endorsed by all colleges, so we're really hoping that the uptake and implementation is much more significant. I've mentioned the app in development, which will include decision trees and refeeding, use of the Mental Health Act, which is often, a difficult path to navigate in terms of when would that be indicated. So there's going to be real clarity about that, as well as the risk assessment being available in the app, like it has been in the junior marzipan version. And there's summary sheets by profession, and I've included in the resources the ones specifically for GPs and primary care. This is a one-page document, which is just a really good checklist that, this might be having it with the risk assessment in your practices as a go-to, because it just outlines the different areas and a checklist to work through systematically to really complete that risk assessment. The whole MEED guideline is over 182 pages long, so there's I've highlighted just a few pages that are particularly relevant and that you can have, and obviously if you then need any more detailed guidance, you can go to the whole guideline, which is on the Royal College of Psychiatry site, and I've included the link in the resources. This is the risk assessment. Now, in terms of today, we're not going to be going through this in any detail, but an offer, if anybody would find this useful, and I don't know if it might be one person who might have an interest and then might be able to disseminate it amongst the group. But we're looking at providing over the Provider Collaborative, which is our group that sits over the Northwest and looks at inpatient admissions. We're looking to have a day where we go through more detailed discussion and the detail around the MEED guidelines, including the risk assessment and the management. So if anybody would be interested in coming to a more detailed day, then please just get in touch. The email of the service is within the presentation, so be very happy to hear from you. For the purposes of today and the time we've got available, I've just included the risk assessment, and what you can see is, very similar to junior marzipan, but this is now all age, that it categorises in the different parameters of that assessment into green, amber and red. So this, is very thorough. A GP, I was on the phone to a GP on Friday, not from your area, but from Wigan, who had worked her way through that. We've not delivered training yet to the Wigan area, but I found this by Googling it and had worked, a way through that and, made contact in terms of thinking about next steps. But I found that a very, helpful and systematic tool to guide her risk assessment, and I found that very comprehensive. So it'll be really good to hear in terms of if you are using that with anybody, any feedback about how you're finding that, and that could obviously come through to commissioners or directly to our service. In terms of the bit I've not included, just going back a page, is the management, but I have highlighted the pages. So when you've completed your risk assessment, which does now include all the other areas, so not just focused on BMI, there is then a very clear table that looks at how that should be managed, and again in terms of who should be doing those various bits, from correcting low potassium to then potentially thinking about more intensive pathways, or when somebody should be presenting at A&E. The other bit of the guideline that I wanted to just flag up today is this very useful 2-page summary document, and there's one written for each profession and each setting that people might present in, and over just 2 pages it runs through the kind of what the role is of different professions in this situation. So in terms of for primary care, the risk assessment, thinking about the location of care in terms of safe feeding and where that might happen, through then to some of the challenges that may come through to completing that assessment, or in terms of people trying to implement changes at home, through to those supporting, thinking about the point where compulsory admission and treatment may be needed, which is generally in a very small number of cases, and a specific bit on people with comorbid type 1 diabetes. Again, in terms of just, I guess, linking back to our service and how we can support now, how we are aiming to support you in the future. At the moment, you can call. So if you complete your risk assessment, if you're very worried, it would be getting in touch with us. We can think with you about if somebody needs that more intensive treatment and organise the referral, or if somebody needs to present to A&E and have a medical admission for that stabilisation. We have dietitians who can help in terms of and if it's somebody who's already known and in our service, who can look at the refeeding plan and to then be evaluating the effectiveness of that. In terms of the future, in terms of recruiting a psychiatrist to help us to manage the medical side, and that support for yourselves in terms of anybody who you are monitoring or who comes to a consultation who you're concerned about, then that will be the part that we are aiming to then launch as soon as we get somebody into that post. So we'll be able to update by your commissioner, our commissioners, and again, happy to do another session at that point if there are any particular parts of the pathway and medical monitoring and management, specifically that you would like a medic from our service to help with. Just going to very briefly just move on to mention about the strategy for implementation. This is part of our awareness raising, so really, you know, pleased that people have come along, and if you're listening to this afterwards, that you've found time amidst, and I'm showing an incredibly busy schedule, but to think about the needs of this group. There is some cultural change that we are looking to support with, because I think some of the blocks when people attend at some of our emergency departments is around people not feeling they've got specialist knowledge, specialist skills, that people need to be in Cheadle. And what we're doing is supporting a wider piece of work with the acute hospitals, which there's already quite a lot gone on at Fairfield, and developing protocols with them for their emergency department and their wards, but around the role that they have when somebody is medically unstable and, you know, too unwell for a specialist eating disorder unit and needs a piece of work first, which might be around refeeding and moving through that risky refeeding kind of piece of work and be more medically stabilised to then transfer over. Training, as I've mentioned, we are looking to then deliver more detailed training, and as I've said, if anyone's interested, please contact me at the service. We're looking to support in the development of a standardised operating procedure for our acute hospitals, so that across any of our areas, if anybody attends an emergency department, they get a standardised and good response, and people are clear about what the response should be, and they are referring and utilising the MEED checklist as part of that. We're then looking to develop a MEED oversight group, which would be a group that looks at admissions and presentations to any part of the healthcare settings, and looks at how you know, the outcomes, how have they gone, what can we learn from that if things could have been improved, and to also maintain training and awareness of future developments in MEED as well. We're planning to have 2 subgroups, so an adult and a children and young persons group, but then for those 2 groups to come together as well to look at issues across all ages. So that's what we are planning to do to really support these guidelines being implemented, and it to be improved care for this group who are often, you know, very seriously unwell with an eating disorder. I'll mention the resources now, and then I'll hand over to Angela, just so that I don't need to come back to this presentation. There is the link in the presentation to the MEED guidelines. There's also then the link to the Annex 1, which has the summary sheet for GPs in. There's also a summary sheet for nurses and a summary sheet for service users and carers as well. So they're the 2-page documents that I've included as part of the presentation. Just a little bit wider in terms of eating disorders more generally, from particularly from the inquests at Cambridge, there is a lot, you've probably heard of this through your own channels, about improving knowledge of eating disorders across a number of settings, and that being, you know, quite an overlooked area in a lot of curricula of professions. So there is some new e-learning training, and that's the site for that. At present, there is training for doctors and nurses, but they are planning, supported by Health Education England and BEAT, to release training on the same site for pharmacists, dentists, dietitians and a range of other professionals as well. I've also included BEAT. You may be familiar with BEAT, but they're the UK's national eating disorder charity. If you are not aware of BEAT, and they've got a lot of resources on their site for both patients with eating disorders and lots of resources for carers as well. And they've got a new bit called The Pod, which has got lots of videos in it about lots of different, you know, often challenging situations and you know, giving ideas of how family members, partners can sort of navigate those at home. BEAT also has a number of online support groups for the different presentations. So in terms of anybody who, while we're working our way through the waiters, if anybody, you know, is in a position to utilise support, then those options on BEAT, you know, are you know, kind of a good option, and you know, provide some evidence-based support for the meantime.
That's great, Magdalene. Just a very quick question that's come through. I've answered the
Yeah.
rest, but can you please explain what MBMI means? And I think it's from slide 12, where it's the measurement with the under 18s, I think.
Yeah, it's the median BMI. So where that's come from is you may know that in the junior marzipan and in children and young persons services, the previously, and you'll still see this used, height for weight rather than BMI. What with MEED coming in, what services are now moving to, and in the risk assessment, is having a median BMI, which is thought to be more reliable. So that's the reference to that.
Thank you.
Anything else in the chat, Kelly?
No, I think that's everything that's come through so far. Thanks.
Lovely. So I'm going to, somebody's just got a hand up. Is that Leanne?
Sorry, yeah, it's me that put the question, and I still I'm not clear on this MBMI. Median of what? You mean a BMI taken over a time period? On what time period? What are you looking at?
Angela,
do you want me to say
there?
a bit more about that, Max? Yeah, so there are charts that you can get for children and young people, which kind of chart how BMI changes across the age ranges for boys and girls, and there are charts for median BMI. So what you would do is you would look at what the person's current BMI is, and then you would use the charts to look at what the median BMI was for somebody of that age and sex, and then you would calculate their BMI as a percentage of that median BMI, and anything below 70% of median BMI would be classed as very high risk.
Okay, thank you.
Does that make it any clearer?
Yeah, I haven't seen those charts. It's new to me. So
yeah, there's similar charts to the child's growth charts that you get for weight and height. You also get the BMI charts that look very similar to those. So you can look at the median, the 50th centile line on those charts is your median BMI.
Leanne, what I'm wondering is, if you haven't got those, our the children and young persons EDS might be able to just share those with you if you want to pop your email of your practice in the chat, and you know, them you know, we're happy to ask if they can send them through.
Presumably you'd be able to go. I mean, you can
It
Google
will,
the
I mean, yeah,
charts.
I mean, it will be available, but yeah, if you want to see what you know, and so it's consistent with how they're risk assessing, we, you know, be very happy to ask my counterpart in that team.
Okay, thank you.
No problem. Any other questions before I hand over to Angela and we hear about refeeding?
Yeah, it's just about how to get hold of the charts, but I think you just answered that, so maybe we can make this available on SharePoint after.
No problem. So I'm going to hand over to Angela Hughes now, who's our senior dietitian, to talk specifically about refeeding syndrome. because that, as you know, as I've outlined, as you're aware, that was one of the reasons why marzipan and now MEED has been developed, because of concerns around refeeding syndrome, at times then people being underfed. Does that come through okay?
Yes, yeah, it's not in slideshow format though.
No,
It's still
it's just frozen. So I'm just it might be that it's coming back to life. There we go. Sorry, Angela.
no problem.
Apologies, everyone. It's just, I think it's just Teams, but it will. I think we're up and running now, aren't we?
Yeah, that looks fine now. Thanks, Mag. Hello, everybody. So as Mag said, I'm just going to give a brief overview this afternoon about refeeding syndrome and its management in patients with eating disorders, particularly referring to the MEED guidance regarding this. Is that sticking again, Mag? Sir?
It's just sticking. So if you just bear with me.
No problem. So starting with a quick recap on what refeeding syndrome is. The term refers to the shift in fluid and mineral balance which can occur in the early stages of refeeding malnourished patients, and it's due to hormonal and metabolic changes. So if we think about what happens in the fasted state, there's a depletion of body carbohydrate reserves. As a result of that, insulin levels fall and fat is used as the main source of energy by the body. Then when there's a change into the kind of refeeding process, more carbohydrate becomes available to the body, insulin levels increase, and that results in increased uptake of minerals from the bloodstream into the body cells. As a result of that, blood levels of potassium, magnesium and phosphate may drop, and you can also sometimes notice drops in blood sugar level and thiamine levels, and there can be edema as well. As regards a more specific definition of refeeding syndrome and its clinical and laboratory features, there are quite a number of different definitions, but this is one of the ones that's most commonly used. So it's defined as severely low electrolytes, that being potassium below 2.5, phosphate below 0.32, and magnesium below 0.5. The second defining feature is peripheral edema or acute circulatory fluid overload. And the third feature is disturbance to organ function, including respiratory failure, cardiac failure, or pulmonary edema, also raised liver transaminase levels. And I find that patients often ask, how would I know if I was starting to develop refeeding syndrome? Would I get any kind of signs and symptoms? What should I look out for? So this table is just to summarize some of the most common signs and symptoms that people might notice. So first of all, cardiac. So you've got things like irregular pulse rate, low blood pressure, and cardiac arrhythmias. Respiratory wise, you can get shortness of breath or general breathing difficulties. Neurological symptoms might include things like tremors, numbness, pins and needles, seizures, or cognitive changes such as confusion. And then there can be a range of other symptoms as well, including things like muscle twitching or muscle weakness, edema and general lethargy. As regards the timescale for when refeeding syndrome occurs, it's most common within the first 72 hours of starting refeeding, with a kind of range of 1 to 5 days after starting refeeding. But particularly in the most malnourished patients, it can occur later, so there can be a bit of a delay, and there have been documented cases where it has developed 2 to 3 weeks after starting refeeding. And MEED also gives us quite clear guidance on which patients with eating disorders are at high risk of refeeding syndrome. So the people who are classed as being high risk have any of these features. So first of all, very low BMI, which is classed as less than 13 in adults, or less than 70% of median BMI in children or adolescents. Weight loss more than 15% of body weight in the last 3 months. Minimal or no intake for more than 3 or 4 days. Abnormal electrolytes. White blood cell count below 3.8. Or any other kind of medical comorbidity or complications before actually starting the refeeding process. So examples might include things like serious infection, cardiac disease, liver disease, alcohol misuse, or any other evidence of any kind of acute inflammatory response. So for example, raised CRP or low albumin levels. As regards managing the risk of refeeding syndrome, one of the things that's recommended in the new MEED guidance, which kind of relates to the previous slide where I identified the high risk factors, is that MEED actually recommends that anybody who is classed as high risk of refeeding syndrome should usually be managed in an acute medical environment because of the level of risk involved during the refeeding process. Then thinking about more specific considerations during the refeeding process, one of the things that's important to think about is vitamin and mineral supplementation. And it's recommended that should be started before commencing refeeding and for the first 7 to 10 days until the patient is medically stable. But that guidance is aimed predominantly at inpatients, and obviously we're also thinking about community-based patients as well, particularly in our team. And we feel that often the refeeding vitamin supplementation is required for longer than 7 to 10 days, because that at-risk period is often prolonged in the community, because we find that sometimes our patients might start the refeeding process, then they might start to restrict again, and so it's much more of a kind of on-off process in the community. So you can find that at-risk period for refeeding syndrome is actually prolonged in the community setting compared with if somebody was being refed in a hospital setting. As regards the type of supplementation that's recommended in MEED, first of all, it's recommended that for inpatients, often it's appropriate to give Pabrinex, either IV or IM first. And then for all patients, whether inpatient or outpatients, it's recommended to give oral thiamine, vitamin B compound strong, and a balanced multivitamin and trace element preparation such as Forceval in the doses that are specified in that table. Another addition to the guidance as regards supplementation, which has just been added in the MEED guidance and wasn't really mentioned in Marzipan, is guidance about phosphate supplementation. So it's recommended that particularly in people at highest risk of refeeding syndrome, it may be appropriate to give prophylactic phosphate supplementation of 500 milligrams BD for adults, but that recommendation is not made for children and young people because there's less evidence to support that. Other advice in MEED regarding vitamin and mineral supplementation And this kind of links in with some of the case studies that Max mentioned. So it's recommended that electrolyte abnormalities should be corrected with appropriate supplementation before starting refeeding, but not to delay commencing refeeding, even if electrolytes are abnormal. So as soon as you've actually put that supplementation in place, you don't have to wait to check that the blood levels have returned to normal. Refeeding should be commenced as soon as the supplementation is in place. Another thing that's important to consider as regards managing refeeding syndrome risk is what is an appropriate rate of refeeding. So it's generally agreed that it's safest if you increase somebody's nutritional intake gradually. Traditionally, refeeding in patients with eating disorders used to be started as low as 5 calories per kilogram per day for people at high risk of refeeding syndrome. And that was based on the NICE guidance on nutritional support in adults, which wasn't really aimed at eating disorder patients, but a lot of people applied that advice to eating disorder patients anyway. Then in the marzipan guidance, it was recognised, again, Mags has already mentioned this, that sometimes people were approaching refeeding so cautiously that there was a risk of underfeeding syndrome, where patients were actually becoming more malnourished and in some cases were dying as a result of that. So marzipan recommended that for most patients, except those at highest risk, it was actually safe to start at about 20 calories per kilogram. Recent studies actually suggest that it's safe to start for a lot of people at a higher rate than that, provided that it's accompanied by close monitoring and appropriate electrolyte replacement. So the guidance that's given in MEED regarding starting rates for refeeding is for adults. If they're identified as being low or medium risk of refeeding syndrome, it's safe to start at 30 to 35 calories per kilogram. But for anyone who's got any of the high risk factors for refeeding syndrome, which I mentioned on the previous slide, then you should be starting at 10 to 20 calories per kilogram. And then from that point onwards, the aim is to increase by 5 calories per kilogram per day every couple of days until you reach about 60 calories per kilogram, and they're achieving a weight gain of at least 0.5 kilograms per week. For children and young people, there have been a lot more studies done on the safety of more rapid refeeding in children and young people. And so it's recommended that for most children and young people, it's safe to start somewhere between 1,400 to 2,000 calories per day, increasing by 200 calories a day until you get to around 2,400 calories, or again, until they're gaining at least 0.5 kilograms per week. It's also stated in the MEED guidance, though, that no patient should be started on a lower calorie intake than they were having prior to admission. So with the kind of people we see in the community, a lot of them would fall into the kind of lower medium risk for refeeding syndrome. So we would probably be looking at starting them on the 30 to 35 calories. But for those at high risk of refeeding syndrome, they would often be in a hospital setting. So in that kind of situation, it would be starting them on 10 to 20 calories per kilogram. Then other things to consider in relation to refeeding risk are limiting carbohydrate intake during the early stages of refeeding. And that kind of links in with what I explained on the first slide about as you refeed somebody, their insulin levels increase, and that can be one of the things that drives the shift in electrolytes. So if somebody has a very high carbohydrate intake in the early stages of refeeding, that can potentially increase the risk of electrolyte disturbance. It's also important to try and encourage foods and fluids that are rich in phosphate, again, to try and prevent that significant reduction in phosphate levels. So a good example is dairy products like milk and yogurt. Then, as regards blood monitoring of people at high risk of refeeding syndrome, it's recommended that high-risk patients should have daily blood monitoring for days 1 to 5 of refeeding. And as I mentioned before, it's also recommended in MEED that most of those patients who are classed as being high risk are also recommended to be managed in an acute medical environment so that level of monitoring can actually occur. And it's also recommended to repeat blood monitoring in 7 to 10 days after starting refeeding in case there's any delayed refeeding syndrome. For those being refed in the community, the guidelines aren't quite as clear. It does state in MEED that each person should have an individualised plan as regards the frequency of blood monitoring, but it gives a general recommendation that once or twice weekly blood monitoring for patients at low or medium risk is recommended. So that's just a very quick overview, but if we've got time for any questions, I'm happy to try and answer them.
Thanks, Angela. That was really a really good summary of refeeding syndrome and its management. We've just got a couple of minutes left, but I'm happy to stay on if people don't have to dash off for a few minutes, if there are any burning questions. Catherine, I can see your hand up.
Thank you. Thanks for that. It's really, really helpful. And obviously I was involved in the inquest and the Regulation 28. So my question is a bit more strategic. And is there any support that you need to spread the word about obviously the guidance? Is there anything we need to do with hospitals locally? Because obviously the criticisms that people didn't know the previous guidance, did they? So what help do you need really? Is there anything that we can do as a system to support you?
Yeah, thanks, and thanks for the offer of support. Really welcomed. I think I went fairly briefly over it because I was conscious that this group might be more interested in some of the clinical aspects rather than the strategy. But I guess this is the day of, as part of awareness raising across the board. The guidelines went out, Kelly, you distributed, I think those through GP leads, didn't you? Which was fantastic. Then we've got some more detailed work going on, which already started, kind of in December time with Fairfield. And where we are up to with that is those protocols have been developed for the emergency department and for ward staff in terms of dietetic nursing protocols and their awareness of MEED. I think will be a continuing piece of work. That's kind of then spread more over NCA as well, because we're looking for that standardisation. And what we know is people living in Bury may go to Oldham or may go to another hospital. So we're really keen that this is standardised across our GMH footprint and wider. And then, as I've mentioned, the bit that will be really key as well, so that we keep, kind of awareness and good practice around MEED is, kind of that, that buy-in from all partners and, kind of that oversight group, which again, in terms of primary care, key role here. So if there was somebody who had an interest, as well as commissioners, to join us in that oversight group, that would be really, really, important and welcomed. And I'm happy, Catherine, for us to catch up outside and join with Kelly about, any other specific bits, and really appreciate your support for the work we're trying to do around this.
Oh, thank you. Well, if you include us in the wider group, and we'll see from a commission perspective who can attend from us to support that. Thank you. Thanks.
Yeah, that's great. Any other questions from anybody who doesn't need to dash off and get back to busy clinics, I'm sure. Anything else in the chat, Kelly, that you've picked up on?
Please, that's one question. Unfortunately, I missed a bit of it. Do we have the details of referral direction, how to, who to send, contact Because I think it's always been a problem in the past is actually getting your referral to the right person to have an urgent patient flow.
Yeah, was that, can I just clarify, was that about just referral to our community adult eating disorder service, or is this about people who are in need of emergency care or more intensive pathways of
I suppose
inpatient?
both, really. Do we have yeah, I'm not sure, I must have missed maybe one of the slides where the contact details were there regarding.
No problem, let me clarify that for you. So yes, if you, in the presentation, there is our contact details. So we're able to provide, you know, a service to people who are medically stable.
Right.
We appreciate that sometimes there'll be a discussion around, well, actually, who does need that medical admission, and who might be, you know, kind of one for the Priory. So our contact details are on there for the community part of the pathway. We also make the referrals for the intensive part of the pathway, which is Cheadle generally, unless we're looking for an out of area bed, which we really try and avoid. If it's an emergency, what we've got an agreement as part of the provider collaborative over the Northwest is that as long as we have sight of that and are in agreement, that referral can be made by someone else. So if you've got somebody who you are really worried about, it's, to be honest, it's likely that they're going to need to go present at A&E anyway for that medical admission or certainly medical assessment, because they're probably too unwell for Cheadle, and also there'll be a delay to get in a bed anyway, even though beds, you know, are typically available within a couple of weeks. But if it's about the referral for inpatient eating disorder treatment, please get in touch with us and we will discuss that with you and we'll make that referral.
Okay, thanks for that.
No problem. Does that answer that question?
It does, thanks.
Brilliant.
I've put the telephone number and the email address in the chat as well.
That's great. Thanks, Kelly. Any other questions before we finish?
No, thank you much to you both for doing that. That's excellent.
Great. Well, I hope that's been useful. And, you know, if there's anything else in terms of, you know, as an ongoing bit about supporting MEED, and as I say, happy to come back when we are more mobilised in terms of our community offer to discuss, you know, how things are working at that point and pick up any issues. Great.
Thanks.